So I welcome everyone to a unique grand rounds. We have three speakers today, and I'm going to introduce them in the order they are speaking, which is Dr. David Blythe first, Dr. Liore Klein second, and Dr. Leigh Smith third. And I've worked with all of them and have the pleasure of working with all of them, some for a short period and some for a long period. Okay, so let me start. Dr. David Blythe's a medical epidemiologist at the Maryland Department of Health. He received his undergrad and med school training at the University of North Carolina, and he completed internal med training and received public health training at the University of Washington. During that training, he also received a master's of public health. He then worked prestigiously as an EIS officer for the Center for Disease Control. And he was actually assigned, I didn't know this till I saw his bio, he was assigned at the Maryland Department of Health as part of that EIS program. After completing his EIS, he joined the Maryland Department of Health Communicable Disease Control Program, where he serves as a state epidemiologist, director of the Infectious Disease Epi and Outbreak Response Bureau, and principal investigator for the Maryland Emerging Infections Program, which, congratulations, was just recently renewed, and for the Epi and laboratory capacity for the Infectious Disease Cooperative Agreement. He's been involved in a range of public health responses, including Zika, SARS, influenza, Ebola, COVID-19, and Mpox. And he's worked with a number of faculty members in our department for over 20 years. He's also taught in the infectious disease epidemiology course and taught routinely in the observational epi course. And when I was director of that, always said yes, no matter what date I gave him. It was a pleasure to coordinate with him. And as you'll hear, he's done a lot of research collaboration with our group. Liore Klein received her Master's of Science in Public Health, and she's a lab epidemiology coordinator at the Maryland Department of Health Laboratories Administration. In her role, she oversees the non-scientific program management of the Antibiotic Resistance Lab Network at the Maryland Department of Health. She also consults on multi-drug resistant organism outbreak investigations throughout the Mid-Atlantic region and assists with the lab management of the epidemiology and lab capacity. She has an extensive infectious disease work history, which was focused previously on mosquito-borne illness, HIV, sexually transmitted infections, and reproductive health. And I was lucky to work with her for the first time closely on the statewide point prevalence for Acinetobacter and Candida auris that we recently did across 50 facilities. And then Leigh Smith, I think most of you know, or many of you know. She's a faculty member. She's an assistant professor in the Department of Epi and Public Health, and an associate hospital epidemiologist under the direction of Sir Lika, and she's within our division. She completed her fellowship at Johns Hopkins, and she's going to describe a little bit interesting kind of work she does both at our institution and with our group and with the Maryland Department of Health. And she completed a year of applied epi fellowship through the CDC at the Maryland Department of Health. She facilitated and is always passionate about doing outbreak investigations and clusters of infections. Her research is focusing on quality improvement and preventing the transmission of infectious diseases in acute care hospitals and nursing facilities. Thanks very much to all three of you. We look forward to hearing your presentations.
Well, I first of all, I'd like to thank Anthony very much for the introductions, and thank you, Dr. Smith, for asking us to participate today. Happy to join you guys all and see so many people who, many of whom are involved in a lot of the work that we'll be talking about. But this is, as this presentation will be, very much about collaboration between our health department and the university on a range of projects, but today we'll be focusing on some healthcare-associated infection, antibiotic resistance projects. But I wanted to start, because I am a recovering history major, wanted to start with this. And I don't know if we can have, it sounds like we can do question and answer. So I'll ask people, what is this? And I'll exclude Anthony because he and I might be the only ones around who were around when this was actually first.
It looks like the preamble to the Constitution, but it's very hard to read.
It's written in that old script. Yes, it's hard to read. But we the people, yes, this is in fact the Constitution. So if we go to the next slide, Leigh. And as probably most of us know, that the U.S. Constitution established a union of states. There were originally 7 articles. We saw the start to Article 1 there on that previous slide. But and among the things that the Constitution did, established the 3 branches of government, including the legislative branch, the executive branch, and the judicial branch, assigned authorities to the federal government in the Constitution. And then the Constitution over the years has been modified with 27 amendments. The first 10 of those, the Bill of Rights, which was finally fully enacted by 1791. And then these amendments, all 27 of them, have further refined the federal government and placed limits on governments, both state and federal. So, next slide. So here's the quiz question. According to the United States Constitution, which level of government, state or federal, has the primary authority and primary responsibility for public health? I will pause to see who would like to respond. Got 2 choices.
There's an answer in the chat.
Dr. Mann answers state. Anybody? States' rights. Thank you, Cindy Jeppy. Well, let's go to the next slide. The answer is a little complicated, but public health per se, at least certainly not those words, but even the general concept per se is not explicitly mentioned in the U.S. Constitution. So it's not really in there, but this is the 10th Amendment, which says that the powers not delegated to the United States by the Constitution, nor prohibited by it to the states, are reserved to the states respectively or to the people. So what this, in the language of the Constitution, what this means, where it refers to the United States, it's referring specifically to the federal government. So powers not explicitly delegated to the federal government in the Constitution, and powers that are not prohibited by the Constitution to anyone, including the states, those are reserved to the states or to the people. So if we go to the next slide, what this means is that in the United States, the primary authorities and responsibilities for public health actions belong to state governments, not to the federal government. So, we'll talk a lot about CDC and federal role in all this, but in a fundamental way, at least per the Constitution, the authorities and responsibilities for public health actions belong to each of the different states, just to make that part clear. So if we go to the next slide, there are, though, in the Constitution, authorities which affect public health and affect the response to issues that we would all consider public health, and that includes the Commerce Clause, which allows the federal government to regulate commerce between states and with foreign countries. So that includes some authority, at least, to regulate, for example, the drugs and movement of products like drugs and foods between states. The Constitution also gives the federal government the power to spend, and so that allows the federal government to spend money for defense and the general welfare. And then there are various executive powers as well that are spelled out, and those can, for some situations, be used to accomplish public health-related goals. But if we go to the next slide, in addition, as probably many of you know well, the federal government also has responsibility for federal facilities that are located within states. And so if we go to the next slide, that includes a whole range of federal facilities that are important to us here in Maryland, including federal office buildings. So though they are located in Maryland, they're really under federal authority. federal laboratories, including the laboratories of the U.S. Department of Agriculture and the Food and Drug Administration, national parks that are located here in Maryland, federal hospitals like the NIH clinical facility, military installations, of which we have several in Maryland, military hospitals and treatment facilities, which we have at least one, and VA hospitals, which probably some of you are affiliated with. But so all of those are federal entities within Maryland, and the feds have authority over those entities, not the states. But that said, again, getting back to the main point here, the primary authority for public health responses belongs to state governments, and therefore the primary authority for public health surveillance and outbreak response, which we'll be talking about more here in a bit, belongs to state governments. That said, let me describe a little bit just to bring us all to the same page about public health in Maryland. So in Maryland, we have, if we go to the next slide, a state health department, and we fall within the executive branch under the Governor Wes Moore, and then there is the Maryland Department of Health, in which we're based. And our secretary for the last year and a half is Dr. Laura Herrera Scott. Many of you know, been here before, was also at the Baltimore City Health Department, and is now serving as our secretary. And then the health department is divided into several large units, and I have them listed here. They're at the bottom. And I will note that we are the largest state agency in Maryland, both in terms of employees and in terms of budget. We have a very huge budget. But the main aspect of that budget goes to this section of the next to the rightmost section, healthcare financing and Medicaid. So in our state, not in every state, but in our state, the Medicaid program is part of the Department of Health, and that's where the huge budget goes. But we are based over on the far left column, far left box, is the Department of Public Health Services, or the Deputy Secretariat of Public Health Services. And our Deputy Secretary is Nilesh Kalyanaraman, who many of you might know, and he was, prior to coming here, has been both at Healthcare for the Homeless and then also at the Anne Arundel County Department of Health as the health officer for Anne Arundel County, Maryland. Then within Public Health Services, there are a number of different units that are probably what most of us think of as sort of the traditional public health programs. I'm in what's that very bottom unit, and we'll say more about that here in a second, but I'll note that in addition is the Anatomy Board, which is affiliated with the university there at the top, and our laboratories administration, our state public health laboratory, and Liore will talk a lot about the lab part, and our local health departments, which I'll mention as well, and the medical examiner, which I think some of you have connections with. So, but I'm in the Prevention and Health Promotion unit. So if we go to the next slide, this is, for those of you who have not been able to visit, here is our office. We're at 201 Preston Street in Baltimore, and that's our lovely that's your lovely state public health department. And in particular, the part on the right, that big tower on the left with the many windows is the former location for our state public health lab, but they have now moved to a nicer location, which we'll see here in a moment, near the Hopkins campus. But anyway, that's where the state health department is headquartered. Go to the next slide. I'll talk a little more about our program, because the program I'm in is what's called the Infectious Disease Epidemiology and Outbreak Response Bureau. And we address a range of infectious disease issues, including surveillance, outbreak investigations, immunizations, immigrant and refugee health issues and responses, healthcare and antibiotic-resistant infections, TB, zoonotic and vector-borne diseases, and other emerging pathogens. So all those fall within our bureau at the State Health Department. We, just some highlights over the last year, processed over 11.1 million electronic reports of reportable conditions in Maryland. In collaboration with the local health departments, the LHDs responded to more than 500 non-COVID communicable disease outbreaks in Maryland, which is a 15% increase in those non-COVID outbreaks from 2022, and actually the largest number of non-COVID outbreaks we've ever had in Maryland. And that's, if you add in the COVID outbreaks, we've had several thousand outbreaks over the last year. We've also responded to the first locally acquired malaria case in Maryland in more than 40 years. We're currently responding to the second measles case in Maryland in less than a year, both of them in unvaccinated international travelers. And of note, we have conducted more than 80 infection containment responses at Maryland healthcare facilities with highly drug-resistant infections. So you'll hear more about that in a bit. Next slide. Just bringing this up to reiterate that I'm at the State Health Department, but we work very closely, and much of the work that we do is done in concert with our 24 local jurisdictions, the local health departments in Maryland. Here they all are. Next slide. Some highlights again. We had over a real drop in COVID, but over 106,000 lab-confirmed COVID cases last year. Over 10,000, almost 11,000 TB cases. That's a combination of both active and latent TB infection. But just to make the point that TB is still around in Maryland, active TB, but also huge numbers of people who have TB who could benefit from treatment for latent TB but are not yet treated. We have had over 10,000 highly drug-resistant organism infections, which you'll hear more about. We also still have lots of viral hepatitis, GI bacterial infections, Lyme disease, invasive strep cases, meningitis, primarily viral meningitis cases, Legionnaire's disease. So a whole gamut of infections that deal with. And then there's those outbreak numbers I mentioned as well on the right. So if we go to the next slide, I wanted to talk a little about funding, coming back from the original discussion. So we are the State Health Department, and we have the authority for responding to infections and outbreaks and so forth. But our program is more than 75% federally funded, not state funded. So, and this is true in every state in the U.S. So we talk about states are the sort of the boots on the ground, and state and localities are the boots on the ground for public health response. However, everywhere in this country, that state health department, and particularly infectious disease programs, are largely federally funded. And in our case, we have a range of different sources of funds, almost all from CDC, but that includes an immunization cooperative agreement, a TB cooperative agreement, a federal refugee health program funding that comes from DHHS, and as noted before, the emerging infections program, which I'll say briefly more about, and the epidemiology and laboratory capacity for infectious disease, or ELC program. So that's what really funds state health departments. So we in Maryland have EIP funding, Emerging Infections Program funding, and we're one of 12 states now, plus the CDC, USDA, and academic partners that work on issues related to emerging infections. And our focus is on surveillance, applied research, and flexible response to emerging infectious disease issues. And the whole program is divided into 4 major project areas, which here includes FoodNet, which deals with bacterial and other pathogens primarily transmitted through food. And we are working with partners at the University of Maryland on some FoodNet projects now. We're happy to have that new partnership. Something called the Active Bacterial Core Surveillance, or ABCs program, which in our case is primarily handled at Hopkins and under Leigh Harrison, who's been a co-PI on the ABCs program for a long time, and that's diseases like meningococcal meningitis and other invasive bacterial infections. We're involved in surveillance and projects related to the respiratory viruses influenza, COVID, and RSV through something called RespNet. And then finally, in EIP, we are very much involved with healthcare-associated infections and antibiotic-resistant infections through something called the Healthcare Associated Infections Community Interface, or HAIC. And much of the work that we do around healthcare associated infections is AR is supported by EIP. But if we go to the next slide, there's also, as I mentioned, these are the EIP sites in the United States. Show you, so spread around the country. But EPI and lab capacity, or ELC, provides financial support and technical assistance to states to help detect, prevent, and respond to infectious diseases. And this is funding that goes to all states and to some large municipalities and the U.S. territories. And the funding, the ELC funding, expanded exponentially during COVID. And the ELC program is overall divided into major program areas, including cross-cutting epidemiology and lab capacity support, foodborne, waterborne, enteric, and environmentally transmitted diseases, vector-borne diseases like particularly tick-borne and mosquito-borne infections, and then finally, healthcare-associated infections and antibiotic resistance. So EIP and ELC are our main support for HAI and AR-related activities. I think that's my last slide. Not my last slide, sorry. And what sets ELC apart from other federal funding? And this is a slide from CDC, but it's the ELC is established to provide flexible funding that can meet states' changing needs, and so it's supposed to not be a one-size-fits-all, but allows for flexibility within states, which you'll hear about. Oops. And there's also funding for leadership and management support, disease-specific project funding, and allows states to prioritize health topics for us, and then cross-cutting projects and program areas to enhance collaboration between the epidemiologists like me and laboratory like where Liore is, with our local public health departments, and with our partners like you guys at UMB. But there, I will stop.
Hey, hi everyone. Can everybody hear me okay?
Yes, we can hear you.
Okay, great. So this is the Maryland Department of Health Laboratories Administration, and that is our very shiny building. And actually, you can see my office is up there on the 5th floor in that picture. And so that is where we sit. We're right by Hopkins Medical Campus, and we're across from the Kennedy Krieger Institute. Next slide, please. So what I'll be talking about today is just giving an introduction to the Maryland Department of Health Laboratories Administration, or I'll refer to it as MDH Lab or MDPHL, and the federal funding mechanisms that support public health response in Maryland, specifically used by the lab, going to a little bit more detail about what existed pre-COVID and what that COVID expansion has looked like. And then I want to spotlight my program, which is the AR Lab Network program at MDH Lab. So next slide, please. So just an intro to who is at the lab and kind of how we're organized. So our director is Dr. Robert Myers. He is our CLIA director, and he also serves as the chief of our molecular biology division. Our scientific programs are divided into newborn screening, molecular biology, virology and immunology, microbiology, and environmental sciences. We also have 2 regional laboratories in Salisbury and Cumberland, and those mainly do environmental testing. We also have our Office of Laboratory Support Services, which does our data entry, our registration of specimens, our supply, any supply shipments that we have, and we would not survive without them. We have our Division of Fiscal Administration and our Office of Quality Systems and Maintenance. Heather Peters is our QA officer, and so she is our one-stop shop for laboratory quality assurance. And we have our legislative and regulatory programs run by Renee Scurry. Next slide, please. Oh, and our Office of Laboratory Preparedness and Response, which deals with a lot of our bioterrorism work, run by Amy Armitage. So just digging a little bit more into what the different groups at our lab get involved with. So within molecular biology, we've got molecular diagnostics. That's where you'll see a lot of your diagnostic PCR testing for COVID, flu, for vector-borne illness, and a whole host of other things. We've got molecular epidemiology, which is where a lot of the testing that my group does sits. So PCR for carpet venom-resistant organisms, colonization screening for CPOs and for Candida auris. And also they do norovirus testing. And they used to do, this used to be where our PFGE lab sat. And we also have our core sequencing lab, which I forgot to include in this slide, but they are a very important part of our division of molecular biology. And then we have our HIV group. Within virology and immunology, we have, pardon the typos, but we have virus isolation, serology, rabies, and vaccine preventable diseases. And then within microbiology, we've got tuberculosis, clinical bacteriology, enterics, reference bacteriology, and then the AR Lab Network microbe group. And then within division of environmental sciences, we've got environmental microbiology, which deals with our food, our dairy, water microbiology, and then chemistry, which includes radiation. And then we have the division of newborn screening, which the division of newborn screening tests every baby born in Maryland, and does a lot of testing for also babies born in DoD facilities, not just in Maryland, but around the world. And so if you have had a baby in Maryland, or you have been a baby born in Maryland, you may have gotten tested at MDH Lab. Next slide, please. So remembering, that slide that Dr. Blythe had just shown, this is kind of the ELC core grant. And I just want to point out the scale of the core ELC funding that was given in 2022, which has been around pretty standard. So it's 197 million to 64 different recipients. And then if we go to the next slide, we go from 197 million to $43 billion. So clearly this is an explosion of funding, and it's not just for laboratory testing or for straight epi, but we've got $11 billion for laboratory testing, $3.25 billion for infection prevention and control. We've got money for enhanced laboratory systems, contact tracing, and then disease surveillance systems, vaccine support, work towards reopening schools, and other pro-COVID projects. And if you go to the next slide, you can see just the dizzying array of projects that kind of got funded for COVID. And a lot of that work got, so I can speak to kind of the public health lab involvement in COVID funding, but a lot of the COVID funding that was received by the states went to state COVID testing sites, and went to work in confinement facilities, like in our jails and prisons. A lot of it went to work in congregate care settings, or in schools. And so that was kind of those are areas that I can't really speak to. Next slide, please. So additional federal funding that is used by the Public Health Lab. We've got, so a new grant is the Public Health Infrastructure Grant, which really is looking at, which has a large section for laboratory data exchange. So making sure that the laboratory data that we produce is actually able to be utilized for public health action. We've got the emerging infections program that Dr. Blythe pointed out. And then also we have CDC prevention epicenters, which I wanted to call out because University of Maryland is, UMB is a site for the prevention epicenters, and is a really fantastic partner for that. And Johns Hopkins University is also one of our prevention epicenters, which is very cool and very exciting. So next slide, please. So when it comes to how academic partnerships happen for ELC funded activities, so sometimes it happens in the way of sub-awards for specific activities, such as during COVID, both the University of Maryland and Johns Hopkins received sub-awards from the state to help with SARS-CoV-2 sequencing. And then other times it just manifests in the direction of partnership for surveillance and outbreak response activities with academic medical centers. So there's lots of different ways that academic partnerships with public health happen. And where, they continuously evolve, which has been really cool and interesting to see in my 5 years here at MDH. Next slide, please. So I just want to spotlight the program that I work most closely with, which is the AR Lab Network. The AR Lab Network started around 2016 with really this goal to, there was this very nebulous understanding of who was doing testing for MDROs, multi-drug resistant organisms. And it was really hard to figure out a really coordinated national response. And so CDC set about standing up an antibiotic resistance laboratory testing network. And they did it in a very short amount of time. And so they funded, they've given some level of funding to over 60 jurisdictions, including states and territories, and also certain independently funded cities that are eligible to receive their own pot of funding if they serve more than 1.5 million residents. And then they designated 7 regional labs that were able to provide kind of more enhanced testing. So Maryland is the regional lab for the mid-Atlantic states. So we cover from Pennsylvania through South Carolina. And then we also have in the Northeast, Wadsworth Center, which is the New York State Public Health Lab. We've got Tennessee in the Southeast, Wisconsin in the Midwest, Minnesota in the Central region, Utah in the Mountain region, and Washington State Public Health Laboratories in the West. And Maryland has been a regional lab since 2017 or 2016 when the program first got when it was first eligible to apply, and we have been very fortunate to maintain that funding since. And so if you go to the next slide, we can kind of talk through the key focus areas. So in terms of the testing for AR Lab Network, all states do some sort of testing for carbapenem-resistant organisms. These are bacteria that become resistant to our drugs of last resort, our carbapenems, and also have begun to do testing on carbapenemase-producing organisms. So carbapenemases are enzymes that can metabolize carbapenems, and it's one way that bacteria are able to become resistant to carbapenems. And those carbapenemases are located often on a mobile genetic element called a plasmid, which can share its drug resistance with other bacteria within a body, within a person's body, and also can cause large outbreaks of carbapenemase-producing organisms in healthcare facilities. And we also do testing on Candida auris and other drug-resistant Candida species yeasts. We focus on, so Maryland and Tennessee have additional supplemental funding to focus on azole-resistant Aspergillus fumigatus, which is a drug-resistant mold. And Maryland also receives funding to work on drug-resistant Neisseria gonorrhea, along with the Utah, Tennessee, and Washington public health labs. And then there's also additional focus on Clostridium difficile and drug-resistant Streptococcus pneumoniae, which Wisconsin and Minnesota take the reins on. Next slide. So talking about, the national and global public health significance of this work. So, we didn't develop these key focus areas in a vacuum. But so for our fungal testing, these are really linked to really emerging areas of big concern for drug resistance. So the WHO fungal priority pathogens list, which was released in 22 or 23, lists Aspergillus fumigatus and Candida auris as part of their critical priority group for additional testing, additional investigation, and research and development. And the factors leading to prioritization, especially for Aspergillus fumigatus, was the high mortality of invasive aspergillosis, increasing antifungal resistance, and really the paucity of available data to characterize the distribution of Aspergillus fumigatus. We're starting to see a lot more surveillance data for Candida auris, but Aspergillus fumigatus really remains this kind of black box in surveillance, especially in the United States. Next slide, please. And so another kind of look at, what the national significance of these key focus areas. So this is taken from CDC's report. It's a special report in 2022 about the impact of COVID-19 on antimicrobial resistance in the United States. So you can see that in many instances, many MDROs are increasing at a rapid clip. So antifungal resistant Candida auris is increasing rather sharply. And so is drug resistant Neisseria gonorrhea. And so we're really, and even things that areas where cases are decreasing, there's still too many for us to really feel comfortable. And so the work in containment and prevention is still extremely important. And next slide, please. Looking at a local level, for multi-drug resistant organisms, in many instances, we have rather robust surveillance, but in some areas we really don't. So limited surveillance data is available for Aspergillus fumigatus, for example. And there's limited testing options available, even though multi-drug resistant Aspergillus fumigatus has been documented to be found in Virginia and Pennsylvania. And we've also, since we've begun testing more extensively, we've identified even more cases of resistant Aspergillus fumigatus in this region. Next slide, please. So looking at additional local public health significance, Candida auris clinical infections in the state of Maryland are steadily increasing, as are carbapenemase producing organisms. Part of this is increased detection, but also just increased extremely productive outbreaks. And we're starting to see an increase in pan non-susceptible organisms in Maryland as well. And we see increased numbers of clinical and colonized cases of carbapenemase producing organisms and Candida auris, which can create enormous challenges for patient cohorting in healthcare settings. And what's even more challenging is that we're starting to see increasing numbers of patients with co-occurring MDROs. So a patient that has a Candida auris clinical infection and then also is colonized with an NDM producing Klebsiella pneumoniae, which just creates a very large headache for cohorting, as some of you who are in the hospital setting are very well aware. Next slide, please. So when we're looking at lab epi collaboration in the AR lab network, obviously the epidemiology and laboratory capacity grant is generally geared towards improving the abilities of epidemiologists and laboratory to just function and do their daily tasks. But the AR lab network has really been at the forefront of really emphasizing lab epi collaboration and making it a very, very strong component of our work. And so when we're talking about the laboratory testing that we're doing, we're really gearing our testing towards the detection of novel MDROs for investigation. We're gearing our testing towards real-time outbreak detection and containment responses, which Leigh will talk about a little bit more. And we're looking, we look at proactive prevention-based screenings to reduce the overall spread of novel MDROs in high-risk settings. We do molecular epidemiology in order to track the spread of MDROs within a given region. And we are doing antimicrobial susceptibility testing to inform clinical decision-making for hard-to-treat infections of Enterobacteriales, Neisseria gonorrhea, Candida auris, and Aspergillus fumigatus. So we're really looking to make sure that the testing that we do isn't just surveillance because we have an academic interest, although academic interest is wonderful. We want to make sure that the work that we do informs public health action in a very immediate term or near term way. Next slide, please. So being an epidemiologist based at the lab is kind of an interesting role in that I am absolutely not a laboratorian. My last AP bio, my last biology class was AP bio in 10th grade. So I'm absolutely not a laboratorian, but I've had an enormous amount of on-the-job training on the very specific areas of testing that we offer here in Maryland, which has been really a joy. A lot of what I do is translate epi to lab and translate lab to epi. So, a lot of my work involves talking to epidemiologists about how they can incorporate the laboratory findings that we give them into their epi investigations. So thinking through, okay, here's what our lab results are saying. What does this mean for your investigation? And also helping epidemiologists understand what laboratory testing can and can't offer for an investigation. I think that, there's a lot of misunderstanding about what resources are involved in order to generate laboratory findings. And also, there can be some misunderstanding as to, what information a laboratory results can really, how that can move your investigations forward. So a lot of my work involves kind of contextualizing that and helping folks kind of figure out what to do next from a laboratory testing perspective. And then I also am bringing that communication back to the lab as well. So, when we are if we are starting to see increases in specimens that are being brought into the lab from areas we haven't really done a lot of testing with, kind of contextualizing why that's happening, and also helping to kind of prioritize specimens for high priority outbreaks, or kind of figuring out where bottlenecks are for getting information back to epidemiologists. So it's a lot of back and forth. And, that's kind of I have a very limited exposure to being in the field based on, where I sit. But so this is a lot of my work is still very translational between the two groups. But I will turn it over to Leigh to kind of talk through what it looks like to be more application based.
Yeah, thank you. So I'm going to talk a little bit about SEWRS outbreaks and what the health department does. So this past year, I worked during my fellowship. I worked with the group that does healthcare-associated infections as well as multi-drug resistant organisms. And one of the things that we were focusing on, a small part of this was Candida auris in long-term facilities. Candida auris is a multi-drug resistant fungal organism. It's almost exclusively associated with healthcare, and you see it a lot in patients who are in nursing facilities, ventilated facilities, acute care facilities, and patients who have a lot of comorbidities. And so a lot of what the health department does is basic epi investigation. So every time there's a clinical case, they will go out and do case finding. So for an example, if there was a resident at a nursing facility who started having fevers, wasn't feeling well, was transferred to an acute care hospital, and then was found to have an infection with Candida auris, they would automatically be notified. And then what they would do is look at the medical review, see what risk factors that patient had, see what nursing facility that they came from, and really do contact tracing at the nursing facility. and think about screening contacts for colonization, so doing point prevalence studies. They do a lot of point prevalence studies in nursing facilities, and they will potentially repeat them as well, looking at how far Candida auris is spreading in a facility, or if it's still spreading, and looking for different transmission. So it's a lot of active outreach to different facilities. And C. auris, the way we treat colonization, or the way that we prevent colonization, is with good infection control policies. So one of the things that we do is something called an infection control assessment response, or an ICAR, and it's a tool that is systematically used to assess practices and guide quality improvement activities. And it's basically, you can print it out, or it's online, and it's a tool that looks at different aspects of your infection prevention program. So the health department will go specifically to different facilities, and they will observe different activities of infection control. They'll conduct this assessment, this ICAR, and then they'll actively provide feedback to the facility about the infection control gaps that they have. And then afterwards, they'll follow up again to see how that feedback has been implemented. And a lot of times they'll go back to the facility and repeat the ICAR to see if those gaps have since been closed. There are different parts of an ICAR and different modules that you would do. And this isn't just for Candida auris. It's for other multi-drug resistant organisms, or just assessing an infection control program. So we can look at training. How is your staff trained? How often are they trained? What does your staff turnover look like in your institution? What does the hand hygiene look like? Is it readily available? What are the transmission-based precautions? Does the staff in your facility understand what the PPE signs mean? Do you have availability of PPE? The environmental services, are we cleaning correctly? And I'll talk a little bit more about that. And then wound care is really big in C. auris, because we know that poor wound care practices can contribute to the transmission of C. auris in nursing facilities. So this is from the CDC best practices for environmental cleaning in resource limited settings. And I think it's important because it goes through a lot of things that we look at when you do an ICAR or looking at environmental services. What is the organization? What is the staffing? Are you understaffed? Are you fully staffed? How often do you train your staff? What is your access to supplies? Are you using the right cleaning equipment? And that's really important for Candida auris, because there's a list of cleaners that you can use that are appropriate for Candida auris. Are you using the correct protective equipment? Are you able to store your supplies correctly? What are your policies that you have? What are your policies for cleaning? And then do they themselves have a monitoring and feedback program? Are they able to give people who are cleaning feedback about how they're doing and further audit? And this is also from the same handbook, and I just think it's interesting to think about all the different processes that go into environmental cleaning. Are you cleaning the room in the right steps, and are you going from cleaner to dirtier areas? And again, this is something that we will physically go to the institution and watch them perform and give them feedback on how to improve. And then we also do fluorescent markers, and I know a lot of people, acute care facilities can do this as well. Basically, you mark the high touch surfaces in the room. You have someone come in and do a terminal clean in the room, and then you come back and you look for those marks that you put as a marker of whether or not the room has been cleaned appropriately. This has been done in multiple ICARs in different states where they've had C. auris outbreaks, and they found breakdowns across the board on infection control. And usually 50% of the marks will still be there in the room after someone has come in and cleaned. So why is it environmental services? Why is it so important for Candida auris? And that's because Candida auris lives on surfaces for a long time, and there's a high burden in nursing facilities, along with persistent colonization and environmental contamination. Originally, when it was seen in the United States, there was a study done in Chicago, and they looked at 490 individuals who were colonized with C. auris. They went to these facilities, they completed the ICARs, and then they did environmental sampling as well. And they sampled 191 places and found that 40% were positive for C. auris. They found C. auris on the glucometers, on the temperature probes that led to outbreaks, ultrasounds, blood pressure cuffs, tables, beds, chairs, doorknobs. And they found that a lot of this was due to breakdown in infection control practices. There's also just a large reservoir on persons who carry this organism. There was also a study that was done in New York from 2013 to 2017, looking at their first 100 cases. And they also did ICARs, and they found that hand hygiene was suboptimal. Hand sanitizers were usually absent. The contact precaution signage was super confusing. There was poor compliance with PPE, and workers didn't know which PPE they should be using based on the signage. EVS was not using the correct cleaners that kill C. auris, and there was just a lack of disinfection equipment. And then they also tested environmental samples and found that they were positive in 15 of the 20 facilities, again, with bed rails, poles, beds, windows, as well as the floor. And just to note that C. auris remains viable on inanimate surfaces for long periods of time, up to 4 weeks, and potentially longer. So if a patient has it and is shedding it in the skin, it's very common to see it all in different points of touch over the room. And one of the other things that we talk about with ICARs is transferring. How are you notifying an accepting institution if your patient has C. auris? And CDC requires that you notify a receiving facility of a patient's, if they have C. auris infection or colonization. And this is one of the prior forms that they use. So really, if a nursing facility is sending someone to an acute care facility, they'll fill this out and send it with them. As a clinician who's worked in multiple states, I'll say it's hit or miss with multi-drug resistant organisms, whether or not you actually do receive these forms. In Maryland, I've gotten alerts from the health department, usually when I have someone come in from a facility who has a multi-drug resistant organism. And then the other thing to note is that C. auris transmission has risen in recent years, and there's been a dramatic increase in 2021. And so, especially in nursing facilities, so transfer communication is extremely important. And we did do basically a point prevalence survey that was done jointly with MDH as well as individuals from the Department of Epi and Public Health. And we found that C. auris was identified in about 6.6 individuals receiving mechanical ventilation in Maryland. And I just want to end with this epi curve that was provided from the Maryland Department of Health, looking at C. auris cases throughout, starting in 2019 to present. And just note that consistent with what we're seeing around the US, our clinical and cases are going up. And that it's really important to have the lab capacity to test, as well as to have the infection prevention expertise that the health department provides to help stop transmission. And I will just go to the last slide for time. I just wanted to acknowledge all the work that the state health department does, in addition to the infection preventionists who do a lot of this work on the ground. I will stop there.
Do you have any questions? Thanks very much, all three of you. Really interesting. I learned a lot. Liore, can you expand a little bit? I was not familiar with the Aspergillus fumigatus. And can you just talk a little bit about what Maryland's doing and or what other states it appears to be appearing in?
I would love to, because it's my big soapbox, because we don't have any isolates from Maryland. Aspergillus fumigatus is a drug-resistant mold that it's actually very common to find throughout. I mean, we breathe in Aspergillus fumigatus spores probably all the time, and usually it's not an issue, but folks with who are immunocompromised can develop invasive aspergillosis. And resistance to azoles, azole antimicrobials happens in two different ways. So the first way is kind of in patient-acquired resistance, where an immunocompromised patient is just on treatment for azole antifungals for a really long time, and then within the patient, the Aspergillus fumigatus kind of acquires resistance to that drug just due to constant exposure. And then the second way, which is the way that we're more concerned with, epidemiologically speaking, is through the application of azole fungicides in agriculture. So the azole fungicides used in agriculture are very similar to the drugs that we give to patients, which means that Aspergillus fumigatus in the environment can acquire resistance due to exposure to azole fungicides. And then, so the Aspergillus fumigatus spores that patients breathe in are already coming into their bodies resistant to azoles. So that's that, and there's a specific genetic marker. When you sequence Aspergillus fumigatus, you can look for a specific genetic marker that is very closely linked to resistance to azoles. That's basically because of exposure to azole fungicides. So surveillance for Aspergillus fumigatus in the United States has been rather paltry. There haven't been a ton of facilities that have been really involved in Aspergillus fumigatus surveillance. And so CDC really worked to kind of expand out the capacity to test for Aspergillus fumigatus, because among public health labs, there wasn't really a ton of capacity to test for these. So what we do is a screening assay where we basically we play out the Aspergillus fumigatus kind of in the presence of drug. We're not trying to get minimum inhibitory concentrations to really tell if this is susceptible or non-susceptible. We're just trying to figure out, like, will it grow in the presence of drug? And if it grows in the presence of drug, then we will do kind of more involved antifungal susceptibility testing to really tell, I think another challenge with Aspergillus fumigatus is that there aren't a lot of clinically established breakpoints. So when you're offering antibiotic therapy, you're going off of the clinically established breakpoints to tell how much of a dose you can, what's a therapeutic dose, and also when you're doing MICs, what is actually a reasonable, what you can reasonably assume something is resistant or susceptible. And so there aren't a lot of really CLSI approved breakpoints for Aspergillus fumigatus, which is challenging. And so also part of what we're doing with CDC is just kind of gathering a lot of data, so that way when we need, CDC uses a lot of those data that we give to them in order to kind of gather data for CLSI submissions to kind of establish those breakpoints in the future. And so a lot of the isolate submissions that we've been receiving over time has been through just folks who were sending isolates to CDC for years, and then CDC kind of shunted that off to us in Tennessee. And so what we've really been trying to do kind of over the last few years is to grow that submission pool, so that way we can get isolates from more places and really kind of broaden submissions.
We're at time, so thank you for having us come and talk. And if you guys have any more questions, feel free to reach out to us.